let's say an older couple goes to Cancun and they're enjoying carnita tacos there, basically pork, okay? And then 1 month later, the dude comes in with the new onset seizures and he does not have a history of epilepsy, okay? So kind of a neuro tie-up, but what do you want to do if the patient presents with new onset seizures? So MRI and EEG, okay? And then MRI, let's say, shows cysts with surrounding edema, okay? Vasogenic edema or something, basically cyst, okay? It doesn't have to be one, it can be like 15 or 20 cysts too, okay? So what are you thinking? Basically a recent trip to Mexico, Cancun or something, and pork, and 1 month later seizures and a cyst in the brain or multiple cysts. Yep, Neurocysticercosis, okay? Most commonly presents with seizures and increased intracranial pressure. So patient can also have like papilledema, headache, and vision changes, okay? And like stroke-like symptoms too, okay? But look for seizures. Seizures are the most frequent presentation, and look for like travel to like Latin America or sub-Saharan Africa. So like look for Mexico, okay? Or some other country, right? And what's the organism responsible for this? Tinea solium, okay? And then how do you diagnose? MRI, okay? But CT is more sensitive for calcified lesions, okay? And then how do you confirm it? So serologic testing with the ELISA. So basically what I'm trying to say is they don't need like a biopsy, because brain biopsy, generally speaking, not a great idea, right? And then how do you treat it? So first line is albendazole, okay, 4 to 6 weeks, and if that's not working, or if whatever allergy or something, then praziquantel, okay. But you also need to put them on steroids, and you also need to put them on anti-epileptic drugs for seizure control, right? So again, kind of like a neuro tie-up. But when do you put a patient with first time seizure on anti-seizure therapy? Whenever they have something on MRI that puts them on high risk for seizures, or they have epileptoform changes on EEG, which means that they have high risk of seizures, okay? Similar question, what if a patient presents to you with new onset seizures, okay, but MRI is fine, there is no space occupying lesion, nothing that puts them at risk for seizures, and then EEG is also not showing any high risk features. So would you put them on anti-seizure meds? No, okay? So in other words, for patients who do not have high risk features on MRI or EEG, we put them on anti-seizure medication only if they have had 2 seizures, okay? 2 unprovoked seizures, okay? However, a patient with neurocysticercosis, we put them on anti-seizure meds immediately after the first seizure, because as long as the cyst is there, they're at risk for seizures, right? So hope that's clear, but look for the neuro episodes to get a better hang of it, okay? But anyways, so that's one problem, infectious disease-wise in the brain, neurocysticercosis, okay? There is also a similar problem. So let's say a patient presents with fever, headaches, focal neurodeficits, okay? They got like an episode of otitis media like a few weeks ago, or they got an episode of mastoiditis or sinusitis, or like even like a dental infection, okay, or endocarditis, or let's say that they got like a recent surgery done for like VP shunt placement or something, neurosurgical procedure, okay. So a patient with these risk factors comes with fever, headaches, and focal neurodeficits. So you get an MRI, okay, and then MRI shows ring enhancing lesions. Okay, so what is this? And like I said, they have history of some kind of sinus infection or neurosurgical history. So this is brain abscess. So ring enhancing lesion is almost always an infection, right? And then what other risk factors? So maybe diabetes, right? Or liver cirrhosis, but we're getting ahead of ourselves. Okay, so so that's a brain abscess, right? So you saw that on MRI. So what would you do next? You'll of course get blood cultures, okay, and you can't do an LP, right? Because they of course have a space occupying lesion, right? And they're having symptoms. So if you do like an LP and they have increased intracranial pressure, that's going to cause herniation, right? So anyways, you get blood cultures, and hopefully blood cultures are positive and you get to tailor the antibiotics. But if not, what empiric therapy would you need? So basically it should cover streptococci, staphylococci, and anaerobes and gram-negative bacilli. So basically third generation cephalosporin and metronidazole. So ceftriaxone and metronidazole, okay? And then tailor them based on cultures. And we continued this therapy for 6 weeks, okay? Question, when would we drain a brain abscess? So surgical drainage is only indicated if the lesion is over 2.5 centimeter or the lesion is causing mass effect, okay, or the antibiotic treatment fails, okay? If the lesion is less than 2.5 centimeter and it's not causing mass effect and there's it's improving with antibiotics, you don't need surgical drainage, okay? So yeah, look for, again, this is so important. Look for a recent episode of otitis, sinusitis, dental infections, or neurosurgery, or diabetics, and they have like fever and focal neurodeficits and maybe symptoms of increased intracranial pressure like headache and vision changes, and get an MRI, ring enhancing lesions, brain abscess, get blood cultures, antibiotics for 6 weeks, empiric therapy with ceftriaxone and metronidazole, and then tailor, and then surgery only if lesion over 2.5 centimeter causing mass effect or failure of antibiotic therapy, okay? What if a patient is very old, okay, and they also maybe they're immunosuppressed or something, doesn't have to be HIV, okay? They have cavities in their lungs and they have cutaneous abscesses, and they have symptoms of increased intracranial pressure and fevers and focal neurodeficits, okay? And you get an MRI, and MRI shows ring enhancing lesions. So basically, old patient over 65 years of age, cavities in the lung, abscesses on the skin, and abscess in the brain. What are you thinking? It's TB's sister disease, a less popular sister. Yep, Nocardiosis, okay? So look for older gentlemen and skin abscess and, like I said, cavitations in the lungs, okay? Diagnosis, basically, sputum samples, okay? If the skin abscess is there, then check that with acid fast stain or something like that. And then treatment, Bactrim, okay? For, of course, 6 to 12 months, because TB and its sister bacterium can be hard to treat. So chronic anti-bacterial therapy, okay? And risk factors, like I said, age over 65, but also COPD, bronchiectasis, okay? So you're regular, cowboy type, extra tanned and wearing cowboy boots and smoking and kind of voice sounds like this and very rugged dude, okay? And also immunosuppression, so HIV, AIDS, chemo, etc., okay? What else? So this was mostly non-HIV patients, right? So what if a patient with HIV presents okay, and they have symptoms like fevers and headache, focal neurodeficits. They can also have seizures, right? So something is wrong inside the brain, right? And then you get an MRI, and it shows multiple contrast enhancing lesions, often in the basal ganglia with edema and mass effect. Okay, I'll give you another clue. So the CD4 count is less than 100. So the patient is very non-compliant with their HIV therapy. Their CD4 count is less than 100, and they have multiple contrast-enhancing lesions inside the brain on MRI. Starts with a T. Yep, toxoplasmosis. Okay, so how do you confirm it? So basically, you can get like toxoplasmosis antigen, and also like you can also check CSF, but not a great idea if the patient has lesions inside the brain, right, and symptoms of intracranial pressure. So definitive diagnosis may require response to empiric anti-toxoplasma therapy. So in other words, if the patient has CD4 count less than 100 and it has like MRI has multiple ring enhancing lesion, it's probably toxo, right? So you just start treatment right away, and that's diagnostic. Okay, so what's the first line regimen? Starts with a P. Yep, pyrimethamine, sulfadiazine plus leucovorin. Okay, if patient is intolerant to this, then we can also do Bactrim, okay, or trimethoprim sulfamethoxazole. Okay, but if the patient has significant mass effect or something, then you can use adjunctive corticosteroids too. So if the question stem says something like patient has those multiple contrast enhancing lesions, but also like mass effect or something, then click the option that has steroids in them. And of course, if the patient presented with seizures, then based on our earlier discussion, you have to put them on anti-epileptic drug. Okay, and then since we're on the subject, when do we do prophylaxis for toxoplasmosis? So patients who have CD4 count less than 100, okay, we put them on daily TMP-SMX. Why? Because it also covers pneumocystic gerovasy, PCP, basically. So you kill two birds with one stone, okay, if you put them on Bactrim. So in other words, all patients with HIV, or any patient, even those who don't have HIV, right, if their CD4 cell count is less than 100, you're putting them on Bactrim. Okay. And then follow-up question, when do we stop the patient's prophylaxis? Like if we put the patient on a Bactrim for toxoplasma prophylaxis and PCP prophylaxis together, what's the indication to stop this prophylaxis? So we stop only if the CD4 count is over 200 and stays that way for 6 months. Okay, once it's over 6 months, once it's over 200 for 6 months straight, then we stop the prophylaxis. Okay, since we're talking about toxoplasmosis, there is something you should know. Okay, the boards love this because it's such an easy question to mess up. Okay, so patient with HIV, okay, and he has like focal neurodeficits or seizures or intracranial pressure, whatever. Okay, and you get an MRI, and MRI shows like a single contrast enhancing lesion. Okay, it's not multiple, it's single. Okay, and there is like ring enhancement, like I said, or contrast enhancement, whatever you want to call it. Okay, what is this? Or like they can give you another clue in the question stem that workup for toxoplasmosis or like toxoplasma, like serology was negative, and again the lesion is like one solitary lesion, starts with an L. Yep, lymphoma or like primary CNS lymphoma. So all patients who are immunodeficient, especially HIV patients, they are at risk for primary CNS lymphoma. And it's confusing because it also presents as a ring enhancing lesion, but the differentiating factor in the question stem will be like a solitary lesion, okay, usually speaking. Okay, and then how do you confirm the diagnosis? Of course, MRI will show like a homogeneous structure, right, because it's a lymphoma, but you can get like a CSF analysis to see like the cytology, to see if we can catch some malignant cells. But if no help, then you do something cool. It's very cool sounding. It's called stereotactic brain biopsy. Okay, so cool. Stereotactic brain biopsy. Okay, to confirm with tissue diagnosis. And then treatment, honestly, who gives a shit? You're not gonna be doing chemo, right? So all you need to know is we do like high dose methotrexate based polychemotherapy. Okay, I don't know why like boards ask chemo questions or like salvage therapy or consolidation therapy or like radiation. Like, are we gonna be doing it? Absolutely not, right? So have you seen a PCP or a hospitalist do chemotherapy? No, right? So then why bother? Speaking of dumb things, you know what would be dumb if you put all this hard work in listening to this review and then forget everything in a week or so. So I highly suggest that you check out the review notes, okay? I wrote them really like word by word. So I put a lot of effort in them. So all of this that I'm talking about will be covered. Okay. So if you want to make sure that you don't forget this stuff, check out the review notes. Link is in the description. Okay. All right. Since we're on the subject of opportunistic infection in HIV patients, so all of these are AIDS defining illnesses. So we just talked about toxo. Now, let's say a patient who is HIV positive, okay, and poorly compliant to medications comes in with the progressive dyspnea, fever, non-productive cough, okay, so, you know, a chronic pneumonia kind of picture. And then you get an X-ray, and X-ray shows ground glass, okay, ground glass interstitial infiltrates, and CD4 count is less than 200. Okay, so what is this? HIV patient, CD4 count less than 200, and ground glass opacities. Yep, so PCP or pneumocystis pneumonia. And how do you diagnose? So chest X-ray initially, but that's not diagnostic, right? Ground glass opacities can be anything, right? Basically starts with a B. Yep, bronchoalveolar lavage, okay, or induced sputum, but I mean, come on. Have you ever seen induced sputum being useful? Usually it gets like oral flora, like I haven't personally never seen it. So call up your friendly neighborhood pulmonologist to do a bronchoscopy with bronchoalveolar lavage, okay? And then basically, yeah, if it's positive, then what's the treatment? So first line is Bactrim. Okay, you're seeing a pattern here, right? Bactrim for almost everything. But anyways, and then adjunctive steroids if the patient is very hypoxic and like disease is severe. So if the PaO2 is less than 70 or something, like it means patient is very hypoxic. So give them steroids as well. Okay, and then if this is like a new disease, of course check for HIV and stuff and start like antiretroviral therapy. Okay, but if like patient already has HIV established, then of course like start ART if they're non-compliant or something. Okay, and then one more thing. So yeah, so there's this test called serum beta D glucan. Okay, it's useful as a screening agent. Okay, it's sensitive, but it's not specific. So if it's negative, then PCP is not likely. But if it's positive, it still doesn't mean the patient has PCP. It's a diagnostic tool. So you get an X-ray and you get a bronchoalveolar lavage. Okay, and then lastly, what's the prophylaxis for PCP? So of course, Bactrim, okay? But if that's not an option or like something, or it's not available or patient is intolerant or patient got an AKI or whatever, then you can also do dapsone plus pyrimethamine sulfadazine. So the same medication that we use for toxo treatment can be used as prophylaxis with dapsone for PCP, okay? So basically, if like if the patient's CD4 count goes less than 200, we put them on Bactrim for PCP prophylaxis, right? And then if the CD4 count goes under 100, we have to put them on Toxoplasmosis prophylaxis, right? But luckily, like I said earlier, Bactrim works for both PCP and toxo prophylaxis, so they don't need two separate medications. Just Bactrim will do the job, okay? But if the patient is like intolerant to Bactrim or something, then we have a problem, okay? In that case, dapsone plus sulfadazine, dapsone plus pyrimethamine sulfadazine is gonna cover for both PCP and toxo. So that's an alternative agent for prophylaxis. Okay. Yeah. So the memory aid, PTM or parent teacher meeting. So P for PCP prophylaxis less than 200, okay. T for toxoplasmosis prophylaxis less than 100, and M for MAC prophylaxis less than 50. But honestly, we don't do that anymore. But it's good to remember, because I always forget like the cell count at which we're supposed to do prophylaxis. So PTM, parents teacher meeting, okay. Now speaking of MAC, okay, so basically patient with HIV, of course, non-compliant or something, and their CD4 count is less than 50, they'll present with non-specific systemic symptoms like fever, night sweats, weight loss, fatigue, abdominal pain, hepatomegaly, splenomegaly, lymphadenopathy, okay. MAC is also like TB's less popular sister. So MAC means Mycobacterium avium complex, right? So yeah, MAC in HIV patients is honestly not that important, okay? Just because like patient will have weird non-specific symptoms that could be anything, but look for CD4 count less than 50, okay? And then diagnose with blood cultures, so acid fast bacilli smear, okay? And then treatment, so azithromycin or clarithromycin, so basically a macrolide plus ethambutol, okay? This is the first line therapy, and this is gonna take a while because like I said, TB sister needs 6 to 12 months, okay? And then if patient is not already on ART, start ART, okay? Honestly, what's more important is how MAC presents in immunocompetent patients, so non-HIV patients, okay? So let's say that a patient, okay, he has history of COPD or bronchiectasis or something, okay? Or a patient who's old and they just like went to like I don't know, Cancun again, I guess, and they were in a hot tub, okay? And then after being in the hot tub, they got this chronic cough pneumonia kind of picture, but they were in the hot tub, okay? So that's when you suspect MAC, okay? So that's the pneumonia picture. There's also another type of presentation. So again, older patient with COPD or bronchiectasis has cavities in the lung with like fever, night sweats, weight loss. So kind of looks like TB, but IgRA is negative and TB, whatever testing is negative. So then how do you diagnose MAC? So then you need 2 positive sputum samples or 1 positive bronchoalveolar lavage sample, okay? So that's how you confirm it. And then treatment, like I said, azithromycin or clarithromycin plus ethambutol, okay? So what I'm trying to say is before the exam, do not forget hot tub pneumonia, okay? So if you see a patient who was recently inside a hot tub and then they developed this like chronic weird pneumonia kind of picture, like fever, cough and stuff, but basically they're asking for MAC, and you wanna get like a chest x-ray, of course, but also you wanna get either 2 positive sputum samples for MAC or 1 positive bronchoalveolar lavage sample, and then treatment with azithromycin or clarithromycin plus ethambutol. But also MAC can also present in patients with severe COPD and bronchiectasis with cavitary lesions, but TB workup will be negative, so suspect MAC, okay? Actually, I forgot to talk about one more thing about PCP that we just talked about 5 minutes ago. So we talked about PCP prophylaxis with Bactrim in HIV patients, right? So can you tell me the CD4 counts that I told you about, parents teacher meeting? Yep, so for PCP less than 200, right? Based on the memory aid, right? What about non-HIV patients? So what non-HIV patients need to be put on prophylaxis for PCP? So the most common one, get your math brain working, because high dose steroids, okay? Patients who are on high dose steroids, specifically more than 20 milligrams of prednisone daily for more than 4 weeks, okay? So more than 20 milligrams for more than 30 days, essentially. So 600 milligrams a month. So you'll have to do a lot of math. For example, if the patient is going to be on 40 milligrams of prednisone for 15 days, then that means that they need to be put on Bactrim and so on and so forth. Also, solid organ transplantation, etc. But honestly, not that important. Just remember the the steroid thing. So one way they can ask you something in the question stem is another neurotype. Older woman presents with acute onset blindness and temporal headache, okay, and ESR is crazy high, okay. So what are you thinking? Giant cell arthritis, right? And what's the confirmatory step? You get their vascular biopsy of the temporal artery bilaterally, right? And then these kind of patients need to be on steroids for at least a year. So for patients like these, because they're gonna be on steroids for almost a year, you better put them on Bactrim, okay? So you know what I'm trying to get at, right? So anyways, and then also, like I said, for toxoplasmosis, when do we stop the prophylaxis for PCP in HIV patients? Once the CD4 count has increased to 200 cells or for more than 3 to 6 months, so that's when we stop the prophylaxis for PCP. Same with toxoplasmosis. If the CD4 count is over 200 for 3 to 6 months, then we stop that, okay? What if a patient with established HIV, okay, presents with fever, headache, neck stiffness, altered mental status, and confused and disoriented, and they go into coma or something, okay? And of course, photophobia. So what are you thinking? It's an HIV patient. Yep, so Cryptococcus, right? So, I mean, Cryptococcus can also present like as pulmonary symptoms, but for the purposes of boards, of course, cryptococcal meningitis is the most important, okay? So how do you diagnose? Of course, CSF, but you can also get a cryptococcal serum antigen, and that's like faster because CSF is going to take time. IR is going to give you shit to get this lumbar puncture done. Neuro is going to give you shit. So might as well get the cryptococcal antigen, okay? And then if you do get CSF, what is it going to show? It's going to show a fungal picture, right? Because Cryptococcus is a fungus. And look for India ink in the question stem, okay? Usually we don't do it, but for the purposes of boards, India ink staining, okay? And then lumbar puncture is gonna show, like I said, fungal meningitis. We'll talk about CSF interpretation at some point. I honestly don't remember off the top of my head. But anyway, so what's more important is the treatment, okay? So treatment is kind of complicated. So there are 3 phases of treatment. So there is this called induction therapy, okay? So that's when we put the patient on liposomal amphotericin B and flucytosine for 2 weeks, okay? Then we have consolidation therapy where we put the patient on fluconazole for 8 weeks, okay? But it's high dose, so it's like 400 to 800 milligrams, okay? And then maintenance therapy, okay? So that is for a year. And that's when we put them on fluconazole 200 milligrams per day, okay? And then we also start ART, but this is very important. We start ART around 4 to 6 weeks. Why? Because something very important happens, and I'm gonna tell you about that in a minute, okay? So basically, HIV patient presents with meningitis, suspect cryptococcal meningitis, get like a cryptococcal antigen, but also CSF, and CSF is going to show fungal meningitis picture. India ink stain positive. Treatment is interesting. 2 weeks of amphotericin B with flucytosine, and then 8 weeks of fluconazole 400 to 800 mg, and then like almost a year to a year and a half, or 12 to 18 months of fluconazole 200 mg per day, okay? And then start ART in 4 to 6 weeks. Do not start ART immediately, okay? Extremely important. And we're going to talk about it in a minute, okay? That brings up a very important question. So when do we put the patients on prophylaxis for cryptococcal meningitis? I mean, it sounds pretty scary, right? So basically, patients, okay, who are in high prevalence areas, okay, and they have CD4 count less than 200, we should screen them for cryptococcal antigen, okay? Cryptococcal screening, okay, even if they don't have any symptoms, but their CD4 count is less than 200 and they live in a high prevalence area, we test them for cryptococcal antigen, and if it's positive, then they're at high risk for developing cryptococcal meningitis at some point. So we put them on preemptive fluconazole therapy. Okay, basically high dose fluconazole for 2 weeks, and then like it's complicated, but we start with like high dose, and then eventually we taper down 200 mg, and then once CD4 count is over 200 for like 3 to 6 months, then we stop it. Okay, yeah, so that's the cryptococcal prophylaxis. Okay, let's say that you diagnose a patient with HIV, okay, and their CD4 count is low and everything. Actually, let me ask you this. So what's the test of choice for screening in HIV or screening for HIV? 4th gen HIV assay, okay? And then once that's positive, then we get HIV RNA to quantify how bad is that, and then of course CD counts and stuff. But anyways, so if the question stem says that patient was positive for HIV, okay, and you started them on antiretroviral therapy immediately because you're a good doctor and you don't want to work at Starbucks, okay, and then all of a sudden they get like really bad, like they develop fever and lymphadenopathy, or a ground glass opacities, or any opportunistic infection symptoms, whatever, okay, or they could even develop cryptococcal meningitis, okay, immediately after starting ART. So what is this? Very important. So this is called IRIS, or immune reconstitution inflammatory syndrome. Basically, once you start ART, the patient's patient's immune system bounces back, and they end up with like these really nasty paradoxical worsening of a known treated infection from the past, or unmasking of a new infection that was probably running around in the system, and now that the patient's immune system has like bounced back, it starts to react to that infection. Okay, so it can be anything, right? So most commonly TB iris, okay, and also cryptococcal, okay, and also MAC, okay. So symptoms vary widely from fever, lymphadenopathy, worsening infiltrates, abscesses, sepsis, meningitis, lymphadenitis, neurodeficits, etc. So, I mean, symptoms are non-specific, which is kind of shitty, but look for, like, in question stem, look for a patient who was recently started on antiretroviral therapy for HIV, okay? Diagnosis of exclusion, okay? Yeah, if they have meningitis kind of picture, then work up for cryptococcus. If they have like TB like picture, then work up for TB and etc. Okay, but that's not important. What's most important is that what do you want to do about ART? Because we started them on ART. ART means antiretroviral therapy, by the way, and they developed these symptoms. Do you want to stop antiretroviral therapy? Absolutely not. Okay, so almost always you don't stop antiretroviral therapy. You just treat like their iris with supportive management, give them NSAIDs and treat their symptoms and stuff, but you continue the antiretroviral therapy, except two conditions, okay? Cryptococcal meningitis and CNS TB. These are the only two conditions where you actually wait. You put ART on hold and treat these two and then restart it, okay? That brings me back to what we talked about like 5 minutes ago, right? So if the patient is diagnosed with cryptococcal meningitis, okay, and they're not on antiretroviral therapy, you want to wait 4 to 6 months because of very high risk of iris. Because if you start them immediately while they're having active cryptococcal meningitis, they're going to get iris and they're going to be dead because, yeah, it's going to be bad. So for patients with cryptococcal meningitis, wait 4 to 6 weeks before starting antiretroviral therapy in them. And also the other way around, what they can ask you is patient is newly diagnosed with HIV and you start them on antiretroviral therapy and they end up with a cryptococcal meningitis. So in that case, you start ART, okay? Or they have CNS TB, but honestly not that important for the boards. But in all other cases, ART should always be continued, okay? Hope that makes sense. Oh wow, we're almost at 35 minutes, and we're not even done with HIV yet. ID is big and hard and okay, that sounds bad. ID is tough, okay? But definitely don't let your hard work go to waste, and check out the notes in the description, and I'll see you in the next one.